Hi, in person and on Zoom. It's my pleasure to introduce Dr. Audrey Pettifor, who's professor and associate chair in the Department of Epidemiology at the University of North Carolina in Chapel Hill, and a fellow at the Carolina Population Center, also an honorary professor of public health at the University of Witwatersrand in South Africa. Her research focuses on structural determinants of HIV and STI infections in sub-Saharan Africa, particularly with young women and adolescents. She has expertise in sexual behavior, HIV prevention, HIV testing, structural interventions among adolescents and young adults. She's published extensively in the area of HIV and sexual behavior with youth in sub-Saharan Africa. And she's co-chair of the NIH HIV Prevention Trials Network Adolescent Working Group, and is a member of the NIH NIAID Advisory Council. She's got an MPH and a PhD from UC Berkeley, and she's one of my favorite people in the universe. So with that, I will hand it over to you, Audrey.
Great. Thanks, Sherry. And it's lovely to be here. I can't see any of you online, but there is a little group of us here in the room, which is lovely. So thanks, everybody. So I was saying I was coming out here to visit Sherry for fun, and she's like, "Don't you want to give a talk?" And of course, like 4 months ago, I was like, "Sure." So I was last week, I was like, why did I agree to do this? But it's always good to do talks, especially it helps you to actually focus and have to like review the literature and be like, hey, what is going on right now? So my disclaimer is that I don't consider myself an implementation scientist, and yet like I'm PI of a D43 where we set up an implementation science degree in South Africa at the University of Witwatersrand. And so I've always been the HIV expert, and I have my colleague who is a real implementation scientist, Rahit Ramaswamy. But we've been doing this now for 10 years. We just submitted our renewal to Fogarty, so I feel like I have learned a lot, and it's just interesting also like where we are in the HIV space, I guess, in terms of implementation science versus other disciplines. And I think we still have a lot of like work to do in terms of educating each other. So today I'm gonna talk a little bit about that, specifically in the space of adolescents and HIV. But if I can get the slides, yeah, there we go. So I think this is probably like we all know this, right? But 10 years ago, 15 years ago, in the if we want to call it EBI, like evidence-based interventions and prevention, we were a bit, stymied and like thinking about especially all of like the CDC best practice interventions, and they were very behavioral, right? And we didn't have, we were still trying to find the prevention intervention that could work. And so I think we're in a really great space now, both for care and prevention in terms of art and prep. But as we all know, like there's still huge challenges with implementation and, low uptake and adherence, especially in adolescents, is a huge problem. And I think that's not just true in South Africa. Increasingly, I've been doing work with the Adolescent Trials Network here in the US. And so, I think it's interesting, and I'll show you an example later of like an innovation we've taken from South Africa and are going to try to apply here in the US, because I think there has been a little bit more innovation and creative thinking in some of the endemic settings and globally in HIV prevention that we probably can take a page from and try to apply here, especially in the US, where we have a healthcare system that doesn't really work. Yeah, if you want to call it, is it a healthcare system?
And then need air quotes.
Yeah, exactly. So just specifically South Africa, because that's where I have where I did my dissertation research and have lived and have a long history there. And it is the country with, obviously, for people that don't know, that has the most people living with HIV, but also has one of the biggest ART programs globally. There's still, huge challenges there, especially I would say in the reinitiation. So I think in terms of implementation, thinking about people start art, but then are falling out of the system or are non-adherent. So really thinking about like, how do we get people back into care or re-engaged in care? I think that's like a really important area. For adolescents, initiation rates, this data is from 2019 from Murray Maskew from South Africa, showing that less than 50% of adolescents were thought to be initiating ART, and adherence is obviously much worse. This one study by Brian Zanoni, which is from 2016, estimated only 10% of HIV infected youth were virally suppressed. So I hope that today and close to 2024, with all of the efforts, that is better than 10%. But you know, in all studies, it's generally not great in adolescents. So, and then when we look at PrEP, I mean, I feel like, you know, especially sitting in the research side, we're all like, capnography, like we're jumping into like, you know, long actings. That said, like people are obviously rolling, you know, Truvada out and trying to get oral PrEP out there. But I thought that this review was really interesting by Zhang, just showing that, you know, as in the systematic review, 41% of people discontinued oral PrEP within 6 months, 48% discontinuation in sub-Saharan Africa, and 31% in AGYW. And like any of you that follow this literature kind of see that, like, you know, all these people starting, and by 6 months, it's like nobody's still using PrEP. So it's kind of a question of, you know, what is going on. This is work by Connie Kellum. I forget if this was PrEP pills study, but anyway, 90% PrEP initiation in adolescent girls and young women. 31% of those received a refill at the 1 month time period, and only 20% persisted through 6 months. So that I feel like is kind of a trend throughout the region. That's like not just South Africa, but data from other places as well, that you just don't see people continuing to use daily PrEP in a lot of settings where it's being rolled out. So we have our work cut out for us, right? And I think the big question, you know, talking about prevention, effective adherence, and kind of like how do we get these interventions to people who really need them? I think like there's issues in measurement in terms of like, yeah, just saying like everyone who started, like who's still using it at 6 months, that's like a very crude measure. And we need to be thinking, especially in adolescents where sexual behavior is like not predictable, and we're not recommending 211, like, although in these settings, even in MSM, but like, you know, talking to colleagues, like internet is everywhere. People know, people read, and people are using 211, even if
you just define it, folks.
211, yeah. So 211 is using event-driven PrEP. So using PrEP around a sex act, right? So 2 doses. I should know this exactly, within 24 hours, and then one after, I think it's 12, is it 12 to 12? Anyway, a dose, 1 dose, and then another dose after the sex act, so around the sex act. Say it louder.
Oh, 2 days out. Yeah, just following 2
1
days.
and 2 days.
Yeah, thank you. See, so having worked with adolescent girls and young women, where that's not what we recommend, but talking to colleagues, like people do this stuff, right? Like people figure things out and are going to try and make things work for them. So
And the concern is the biology of women is different.
yes, exactly. But even in MSM and Sub-Saharan Africa, like it's not, if you go into the health center, like it's not recommended in the guidelines, which feels like a kind of, we should be measuring this and asking about it in settings beyond the US.
It is recommended in Brazil. So like there are some places that have introduced it in the guidance, but it's not standard. I mean, the providers don't know about it even. So.
Yeah.
Audrey, I had a question for you. You know, the discontinuation rates, of course, are horrific, but you raised that idea that because risk is quite variable, people may now be adjusting the risk. The countervailing evidence would be that if we see, we see the incidence rates in the people who started, it's like, what do those look like?
Yeah.
I mean, are those telling us that, yeah, these people really are at risk? It's not just they've decided, oh, I'm not really at risk. So what do you see?
I don't know if we have good data on that. Like, I don't know if we're measuring, like, I don't know. I haven't seen data to suggest that. I mean, I know there's some data saying incidence is coming down, but I don't think PrEP is at a level. I mean, this is my personal opinion, and I don't have the evidence, but I don't think PrEP is at a coverage level where we're going to be seeing incidence rates coming down in any of these like national surveys if we're using actual measures of like recent infection or whatever. So I don't know, but if anyone online, like we could talk about that later. I think that is something to be thinking about. My sense is that from like where Tonya Petit and I have a implementation study in South Africa looking at a USAID funded transgender differentiated care model, and even for transgender women in these sites, like when we wrote the grant, it was it was going to be people using PrEP, and now like getting to the actual implementation, starting the trial, like we've had to just change it to people who are interested, or because aren't enough people even on PrEP to have that be the enrollment criteria. So I just feel I just think there's still a long way to go in terms of reaching people who need it. Especially if you're outside of like Johannesburg or like metropolitan areas, So anyway, so yeah, so this is all to say, and I guess just to Sinead Delaney-Moletwe is a close colleague, and her point is always like, how do we think about these within a constrained healthcare system, right? Like all of these places where we're working, obviously, but like I think sometimes we have a tendency, especially in our research, to come up with like complicated interventions to try and address these problems, and we just need to like and I think that's part of the implementation science, and where we need to do a better job is really thinking about like what is going on in these complex health systems. So, and I know Sherry's done a lot of work in that space. So I'm going to talk a little bit about the current state of IS research with adolescents, some of the gaps. I'm going to give an example of two studies that we're doing, one here and one in the US, or one here and one in South Africa. I guess one in South Africa, one in the US. Briefly talk about our D43 and then just end with a few next steps. So this is a review, from 2020, and I couldn't find anything more recent, but it's interesting that Smith and colleagues looked at studies funded by NIH from 2013 to 2018. They went into Reporter and they were looking for HIV and anything that had like implementation science. And I mean, the numbers are somewhat low, but the majority of them, and I think this is a theme throughout, is that most studies are in this implementation preparation, or really not doing a lot of work in the actual so this is like acceptability, feasibility, like the really early stages of implementation is where like the bulk of the research has been. And even in these studies that were, and this is another thing where I think we need to do a better job, most are not using actual implementation science methodologies, even though they are saying like this is an implementation science study, they're not using like frameworks or defining outcomes clearly. So, I think that is a call to us as HIV researchers, and that's sort of preempting my conclusion slide, but if we're saying we're doing implementation science, like we need to do a better job of actually, myself included, like being really clear about like, what is the outcome? What is your acceptability outcome? How are you defining it? Does it tie to any other like standard measures out there? Are you using a framework? What is the framework you're using? So this, if anyone's in implementation science, Enola Proctor is kind of one of the gurus out there who's done a lot of work in this space. And I thought this was really interesting because she did a recent in implementation science just this year, or scoping review from 2011 to 2020 of papers that cited the Proctor outcomes, which is a paper from 2011. And I'll show it to you if you're not familiar with it. But there were 400 studies included in the review. And again, it's the same thing. Most studies focused on earlier metrics of implementation. So here you can look at, these are the outcomes: acceptability, adoption, appropriateness, cost, feasibility, fidelity, penetration, and sustainability. And you can kind of see like where it's this distribution of where, if it was an exploration study, obviously it makes sense that more of the measures are in the acceptability, adoption. You're not going to be looking at sustainability and penetration, most likely, if you're in an early phase of, or you would think you wouldn't be, of the study. But I thought that this take home, there was little evidence of progress in testing the relationship between implementation strategies and implementation outcomes, leaving us ill prepared to know how to achieve implementation success. And I think that's a real theme right now, is that there's just a lot of barriers, facilitators, acceptability, feasibility research out there. And we really, as a field, need to move beyond that and tie together, what are, if our outcome is acceptability, what are the strategies that are actually implementation strategies addressing acceptability? And are we measuring these steps in the process and not just focusing on these upstream, really early determinants? I think some of that is because I don't know, I'd be interested to have a conversation about this. I think NIH does fund us to do kind of efficacy or traditionally efficacy research, right? And we're like, I've developed this new intervention. It's not an evidence-based intervention yet. So I need to show that it works. And so therefore we're not really in the like implementation science phase where we're scaling or trying to show sustainability of some kind of intervention, you know? And so that it may be a product of kind of like where a lot of us sit in our research, but I think that would be interesting to talk about. Yeah, what the NIH does. This is the paper by Proctor, if you don't know it, and these are the implementation outcomes. I know this is like really small, especially in the room, you can't read it, but it was those acceptability adoption. I like this because it just sort of talks about level of analysis, theoretical basis, other terms that people use in the literature, like acceptability satisfaction is another word people use, and it talks about kind of available measurement. So it's a bit old at this point, but I think it's oldie but goodie. Okay, so then Susan Borkhopper, who's at Fogarty, did a scoping review, and she runs the AHISA network, which is the Adolescent HIV Implementation Science Alliance, which Fogarty put together, I think in 2018, 2017, and you kind of had to apply. It's pretty broad now. I know a lot of people, I don't know if it's still application only, but I know they have meetings at least once a year. It's focused in Africa, so it is sort of, adolescent. I think HIV is part of that, right? But so they are, and it's sort of African investigators and US investigators. And I will say the first meeting, which was in Bethesda, was sort of funny because we were all in this room. And when we went around and said, like, what's implementation science and broke into small groups, it was very clear that like 3/4 of the room, like nobody was on the same page about what that meant. And a lot of people were talking about like epi studies and like, we're looking at like determinants of HIV infection. And it's like, no, that's not actually implementation science. So I will say, I think that network has made huge like leaps and bounds, and they've done a lot of like trainings and brought, you know, some of the like big wigs in the field in to do work and have funded kind of pilot studies. I would say it's more of an information sharing and kind of networking group. More, I mean, it's Fogarty more than anything. But they did this review, which was from 2010 to 2011. So it studies just in sub-Saharan Africa, 10 to 24. Again, these were all like studies. So they stated at one implementation science outcome that they were considering or measuring an implementation science outcome. That was sort of the objective. Only 4 of those articles referenced an implementation science framework. Again, need to do better there. And then you can kind of see, again, it's the same kind of thing. The majority of studies were acceptability and feasibility. Very few were looking at things like fidelity or adoption or any other kind of outcome. So the field is very like saturated in that area. So that was just HIV studies in general. Then Susan, this is part of the AHISA network, did a review of people in the AHISA network. So like specifically these investigators who are supposed to be doing adolescent implementation science research in Africa. There were 36 studies, again, better than the other review, but only half of them were using implementation science frameworks or theories. Interestingly, 72% said that they evaluated some kind of implementation strategy. Most studies were focused on earlier phases of implementation. Half of the studies assessed determinants of implementation of evidence-based interventions, and a few explored how specific strategies might overcome barriers. There was very little looking at mechanism moderators or mediators of evidence-based interventions. So that was kind of like the take home there. Again, similar theme across all these reviews. What was interesting is that like the authors of this study called things implementation strategies. The authors themselves were not recognizing, and that's something I noticed a lot, even myself. It's like, is this an evidence-based intervention or is it a strategy? You know, and I think I get myself confused, especially in the prep ART, you know, like, oh, we're doing this like adherence intervention. Is that an EBI or is that an implementation strategy, you know? And so they went in and I feel like defined a lot of things as strategies, but then the take home was that they did not call it that and they didn't really like test or evaluate the strategy. So I think, again, that's something for us to be more conscious of as a field. And not surprisingly, most things were focused on the individual, not on like systems levels, which I think is a take home across the field, not just in implementation science. And this was just a graphic, which is going to tell you the same thing. The darker colors are more, and lighter colors mean there's not a lot there. And you go from acceptability at the top, going down to things like sustainability, maintenance, cost, penetration, and there's very little in those spaces. So theme where the field is. And just when we talk about strategies, I guess this is just to call out this paper by Byron Powell and colleagues. Again, another theme is that most of this theory outcomes was all developed in the US, right? A lot of it's developed in the US VA system. So I think there are really important questions about how these things translate to LMIC settings. And I think that is work we need to do as a field. I know in our D43, that's something we're really trying to work with our scholars on, is like, if you're using this outcome or you're using this framework or whatever, like, does it really fit to the context? And if not, we need to like talk about and write about why it does or doesn't fit to the local context. But they did this Delphi process with experts, Byron and colleagues, to try and come up with like strategies, like what strategies are people, implementation strategies do people use? They, through this process, came up with like 73 strategies.
It's huge.
It's huge. And if you look through it, it really is like, I pulled this one because I thought it was like, you know, promote adaptability, promote network, provide clinical supervision. So these are things you might do, right, to help your intervention, your evidence-based intervention, like be more effective, right? So things like provide clinicians with ongoing supervision, focusing on the innovation, provide training for clinical supervisors who will supervise clinicians who provide the innovation, right? So I just pulled this one because there were some things on it that, you know, revise professional roles, shadow other experts, like tailor strategies. So, you know, they've pulled like generic themes of things people do as and I think it's really helpful. And we have not yet had a grant funded to do this, but we have submitted some grants where we are like, we're going to kind of pull from the ERIC strategies and then do our own like workshopping with providers, you know, in South Africa to try and figure out like what types of things would best align and be most feasible and acceptable to like help, for example, healthcare providers in this setting. But I think it's a nice set, right?
It's a good list. You know, if you're using an implementation science framework and say, you know, you revise CFA or something, and you've got your determinants, it's really nice. It's kind of like, okay, where my lesions are, being able to make sure, choose implementation strategies that are addressing your determinants, or like where things are coming from. So that in that way, even though this is a huge list, it's a great resource to say, okay, these are the determinants I think are important. Okay, what sorts of things could help address that? And then you've got individual and structural and provider level stuff. So in that way, even though it's this huge compendium, you're not meant to do them all.
No. Yeah, it's a compendium. So I would say you like pick your things, and there's probably more than that is not listed there, because this was again US and kind of might have been some European, but predominantly US like people that they
high income centric.
Yeah, that they did the polling on. Okay. So switching gears, so that's kind of like where the field is. So I feel like COVID was this great.
Redact.
No, I mean, so caveat of the terribleness of COVID, and yet I think it pushed us in the research space to take innovations and do things that we can be very slow, and like, let me do my R21 and then I'm going to write my R01. And like, it forced us to look at particularly healthcare delivery in alternative modalities in a way that we just had to do because we had no choice, right? And so I think in terms of the telemedicine, providing care outside of clinics, like that could be a silver lining, I think, of like it made the field move really fast in a way that I don't think would have happened if we hadn't been forced to do it because of a global pandemic. So my colleague, Danielle Jovenko, who's at Emory and was based in Cape Town with the Desmond Tutu HIV Foundation with Linda Gale Becker's group, was in Cape Town when COVID hit. And so ViiV put out a call for kind of looking at the impact of the pandemic on adolescents living with HIV. So Linda Gale's group in Cape Town have done a lot of really innovative healthcare delivery type of models. They've been doing mobile clinics and like other things for years before people were really looking at that. So they have done PrEP. They call it's like Uber delivery for PrEP. So, the little guy on the moped, like delivering PrEP to you. And so we adapted that for art, for adolescents and young people. So this was like, again, in the field of like, also wearing the blame, acceptability, feasibility, preliminary effectiveness, right, of this intervention, delivering art to adolescents living with HIV in Cape Town. And so essentially, interestingly enough, this is where it's always great to have your local investigators. I feel like SMS and cell phone kind of reminders and adherence tend to we just like package it in and say, oh, that's just like standard of care. But Linda Gale was like, it really is not like, it's a lot of work and it's additional, like it's cell phone airtime. It's like making sure, that this can happen. And so she wanted to randomize people to the SMS to like support or not. And then people could choose. So there was a choice of whether you wanted a courier delivery or you just wanted to keep coming to the clinic. So people were still at this point, still coming to the clinic for their ART at this point in the study, which was later I think by the time we actually started it, it was 2021. But
could they switch over time, like, dynamic choice or just upfront choice?
It was upfront choice, but I guess they could. I think the clinic was always there for people to come. And I don't think we have good data on that, to be honest, whether how much like moving around. But this was in Googlet too, which is one of the townships outside of Cape Town. It was young people 13 to 24. They needed to have regular access to a mobile phone with SMS capacity. And they had to have received their HIV treatment from a study clinic. So these were people in care. And I think that was like one of the things. I would say of the group that was in the study, adherence was not terrible to begin with, which I think is like one of these things when we think about like who we're gonna then start to look at cost and adaptive kind of designs. Like, do we really want to be focusing on people who are already doing an okay job? Like, are they the ones who really need courier services, or I think we should be looking at people who are maybe struggling more. But not surprisingly, people liked it. It's helpful. I'd recommend it to a friend. So it was very acceptable. They also liked the SMS messages, which I think is not surprising. And I mean, it's interesting. We were having a conversation debate, another thing we could talk about in these measures of acceptability and cultural context, where we do these studies and really thinking about, the US, people are pretty used to saying like, this was like, what is your expectation for services? First of all, like I expect to go to the doctor and not wait more than like 10 minutes for it to be called back into the room, right? Versus like, I expect to go to the clinic and I could be there all day. And that's my expectation. So if you ask me, like, I waited 4 hours to see someone and they say, oh, it was very acceptable. And you're like, what? You waited 4 hours? Like, that's great. So I just think we need to think more. And that's, I think, an area just in implementation of really thinking a little bit more creatively about cultural context and what, if you just ask people like, was this acceptable? Are you satisfied? We often see really high measures of acceptability when you look at it and say, this does not seem like a service delivery. So
we had a question in the chat.
Yeah.
Someone was wondering if the messages were individualized or standardized.
Good question. I think that they were individualized because this was a pretty small like pilot. So I think that it was actually going to like a study staff member who was responding. It wasn't like an automated like a.
This is your reminder, non-specific,
Yeah.
non-disclosing.
Yeah. So, and this is similar, and we're now adapting kind of like non-clinic delivery for adolescents in the U.S. But I think this is increasingly we're seeing like PrEP delivery in the US, like you can get your, pharmacy delivered drugs to your house, right? But in the studies in the US, it's similar that, the people who choose to go to the clinic are the ones like who say, I prefer to go to the clinic, I prefer to see my doctor, right? So, I wouldn't trust the delivery would be the correct medication. Was small, but not non-significant. I was worried the delivery wouldn't be on time or reliable. Like, these are things we see also in the US of people who say they want to come to the clinic still to get their care. They don't want a box delivered to their house or whatever. Like, there are people who want to see a doctor, who want to actually see a clinician and get care. So that was the group who didn't want Courier. And then, you know, of the ones who wanted, who chose it, right? It was easy, it was convenient, and I didn't have to go to the clinic, right? That was, you know, I guess not surprising, but I think important that as we emphasize choice, like a lot of the work we're doing now with adolescents is really trying to focus on choice of method, but also choice of like venue. It's like, you know, and we know from my background from family planning, and you know, the more choice you offer, the more likely you are to get coverage in general. So I think as we get more choices, there's a lot more research into like, I think thinking about the science of choice, that's not my area, but like how we architect choice for people to help them and providers.
You did have a question as well, whether people were paid to participate in the study?
No, they weren't. And they did get reimbursement for coming in, which is pretty standard practice, but there wasn't like an incentive to come in. But yes, they were reimbursed. Yeah. And I don't know how much, to be honest. This is the I guess like preliminary efficacy. So what you're looking at is the month 3 viral load suppression and the month 6 viral load suppression and prevalence ratios. And from the forest plot, you know, there wasn't a whole lot that was significant. If you received a delivery and there was SMS, but you know, the numbers are really small, you were more likely to be virally suppressed. It trended in that direction in general, not so much at 6 months, you know? And I think some of that may be, it was a highly, you know, we're comparing them to people coming to the clinic versus getting the Courier. So in general, I think that it was a pretty adherent group to begin with. So I think it would be interesting to look at this. And Danielle's looking at submitting this as a larger study. And I think thinking more about, you know, what the eligibility criteria would be for being in a study like this, I think will determine some of that. Looking at you guys who've done some of these.
Might be interesting to look at self-historical controls, like what, you know, since this is so active and it's such a group, it's just like, you know, did it for those people who were kind of the viral load blip people, did it actually just take them up to where everybody else was?
Yeah.
So I don't know how long they were followed on care, but like
this was pretty 6 months. So this was pretty short because it was like a pilot. You know, wasn't. But I agree.
What did you look like last year compared to doing in this?
Yeah, that's a good. And COVID, I mean, I will also say like retention of the cohort was pretty bad. And I think a lot of that had to do with like COVID was just, as is common in South Africa, like people's cell phone numbers change a lot, and particularly in some of these urban areas, people just go AWOL. So I know they had challenges like finding people at 6 months in general.
Were there strict lockdowns?
There was at the very beginning, like right in that March to June, they had really crazy strict lockdowns, and then it kind of opened up. That said, I don't know.
But they also had like some clinic closures in South Africa, so they essentially told the staff like you don't have to come in all the things. They sort of they reduced staff time at the clinics. I mean, it was back up in 2021, but for the second half of most of 2020. Once COVID hit, it's like whether there were folks staffing the clinics was also sort of a question. And I think it probably depended on the clinic in the area.
That said, like we did ask some questions about ART, like their care interruptions during COVID, and there wasn't very much. And actually we had an HIV negative group as part of this study because long, complicated story, but we got combined with another gender-based violence study that had been funded because just like field work was restricted and staff were restricted. So they had to get both studies done. So they kind of put us together. And the kids living with HIV reported like less interruptions to care than like the HIV negative kids who were talking about like family planning or like other preventive services, which maybe is not surprising because those are maybe seen less essential. My understanding was, and again, I think I agree with Sherry, I think it really depended on the clinic, but a lot of clinics were very focused on trying to get HIV care out, whereas I'm sure some of the other services were probably interrupted more than HIV care. But I know I've had colleagues where things really were impacted a lot. Okay, so then transitioning, this is Adolescent Trials Network, which is NICHD funded, and they I guess we're now going into year 2, but year 1 was really, they redid the whole network, so it is very much like a lot of R01s, I guess, like multi-site R01s. So this is a study that Keith Horvath and Kate Messing and I have that is essentially moving to PrEP now, but looking at delivering PrEP outside of the clinic for adolescents. And yeah, we're just maybe have protocol version 1 drafted right now. And a big piece is that it's not just going to be daily PrEP, it's CAB as well. And so a big piece is like how to, delivery of cabotegravir outside of the clinic. And I think right now the sites are Children's Los Angeles, Baylor in Houston, Hopkins in Baltimore, Fenway in Boston, and I think there might be one more site that will be on board that will be doing the intervention. So that right now when we meet in January with the sites, it's a question of what is your out of clinic delivery? We had kind of originally written the protocol like it was going to be a healthcare provider coming to your house. But from meeting with the youth advisory groups, a lot of them are like, like that. So is it going to be a mobile site van for some sites? Is it going to be like a community health center for some? Are there some who are actually going to have a nurse go to your house?
Nurse,
yeah. I mean, we have all the sites budgeted for a traveling health nurse, but it'll be interesting to see how now that in working with their youth advisory boards, it's actually going to take shape and what those models of non-clinic delivery are going to look like. But yeah, so that, and we have acceptability and cost effectiveness as part of that. It's always hard. I still, going back to the beginning of this talk where I'm like, well, we're not measuring these other things. And it's really hard to measure some of these things within clinical trial type of settings, right? Because it's contrived a little bit and you have research sites. They're not standard healthcare centers doing the work. And can you really look at adoption of an intervention if you're going into the clinic and saying, okay, you guys need to here's my study nurse and you're delivering this intervention. It's not, it doesn't really make sense, So I think, again, it's hard to do some of these things.
Yes. Here, take this sustainability survey. It's sure, you're going to have this grant forever.
Right. Right. Exactly. So yeah, we're hopefully starting in the middle of 2024. I will say that, Gilead's providing the drug, and so I think that's going to be our rate limiting step right now. Is when we actually get the drug, so that we can start.
We did have someone interested in knowing if you would consider using AI as well to get demand.
Oh, I don't know. I would love to hear more about that. I know that the Lisa Hightower, Weidman, and Sybil Hosek are the chairs, I guess, of the ATN, and I know there's a whole group in Lisa's shop who are doing demand creation and a lot of web-based, but I do not know enough about AI. And I will say in my experiments with ChatGPT, I'm always like, this is problematic. So I am not the person, but I would love to hear more about ideas of what that would look like.
So you may have the ice cream van cabotegravir, but the cabotegravir van is here.
Yeah.
Is that just coverage? Is it? I mean, that's a really interesting idea. It deals with the stigma issue.
Yeah.
But then it's coverage and what geographic area.
And that's
what's your schedule.
Exactly. And I think from the cost effectiveness, it's funny because originally when we wrote this, we're we want to reach rural adolescents, but if you're going to send a car out an hour and a half to someone's house, to one kid out somewhere, and then they're not there, right? Knowing adolescents, they are you just spent a lot of money to send a nurse out and no care was provided. So, I mean, I don't know, the LA sites, we've been talking about how far out, what is your range? And the same with the Houston site. I have a feeling it's going to end up being more urban than I would like it to be. And I think that but it'll be interesting to see. I totally agree. A big piece is just who's using, what does it look like? Who's using these services and how much was getting to the clinic a barrier beforehand, and is it addressing those structural barriers? If you're in Baltimore, how much was safety or just the clinic hours weren't convenient really a barrier? And is this overcoming those or not? Yeah. Okay, so my last piece is just talking about our D43. So this is with the School of Public Health at the University of Witwatersrand in Johannesburg. And then So when we started this, the first round was setting.
What is a D43?
A D43 is training. I should, my program officer at Fogarty is going to be like, but essentially you are training junior scientists in LMIC settings. This is specifically a D43 on HIV, and you're like training in HIV prevention care to create investigators, as bio is really like create, scientists in LMIC settings. So it is funding. In this case, we have funding for faculty in South Africa who do the training. And the big piece is funding for PhDs. So it's a stipend, it pays for fees. Postdocs, we pay for, like we've done micro grants to junior investigators. And then it does fund, as opposed to a T32, it does provide some funding for the US team who are implementing it, which T32s don't do. So you can have some percent effort as a US faculty member. We can't fund US students. You cannot fund, like we got in trouble for having a master's student kind of helping out, and they were like, no, you can't fund US students. So it is for international
They're
students.
international research training.
Yes.
From Fogarty.
Yes.
Great.
And yeah.
Can I ask, what's the role of ANOVA and ARM and all these?
Yes. So that's where So in the first round, we were just like, we set up a degree and it was a concentration in implementation science at the School of Public Health in the Epibios department. So that was just a lot of work getting that up. And then we funded students to go through the program. Again, Fogarty is very focused on HIV outcomes. They want you to be creating, just like Ks or Fs or T32s, you're supposed to be creating NIH investigators, right? And so this is a very slow pipeline if you're going to be funding master students to get them to be submitting grants to NIH. So in the second round, we partnered with the main HIV implementation groups in Johannesburg. So Wits, RHI, ANOVA, and Orem are all PEPFAR, some of the major PEPFAR implementers in Johannesburg and in South Africa. So we were like, well, let's partner with the folks who are implementing the HIV programs, because the School of Public Health can do training, but they're not out there actually like running programs and doing research on this. So we also started in the second round doing more training of the researchers in these organizations and trying to use that as a pipeline to get people in
Field experience.
Yeah.
That's great.
Yeah, so getting some implementation science like knowledge and baseline kind of in these organizations who are supposed to be doing this work, right? And so that has been more, I think, successful in a lot of ways, because they are doing the work. So we've just resubmitted, and I think again are trying to focus maybe even higher up, continuing to do all of that, but trying to also focus on clinician scientists more in the implementation science space. So this is just one example of one of our scholars, Dr. Chandrai Mabuto, who's at the Orem Institute. And I love this implementation research logic model. It totally speaks to what we were just talking about earlier of trying to tie everything together. But it really makes you look at your outcomes, the implementation strategy, the mechanisms, your barriers, so it ties it all together, right? As opposed to like, I'm just looking at these barriers and then I implemented this strategy. So basically here, you've got like your determinants, your strategies, your mechanisms, and your outcomes. And I just like, when I saw this, I was like, I love this. I like that logic person in my head. So definitely I would say, take a look at this. So Chandra used this to look at a psychosocial support for people on art using motivational interviewing. So they were promoting on-time clinic attendance for art visits, and they wanted a high percentage of clients to be virally suppressed. This was in the Northwest province of South Africa. And they were redefining duties of lay counselors, training case managers, and they had a case manager handbook. But there were concerns as like, this is right, like all of these PEPFAR partners, right? They weren't seeing improvements in indicators. A lot of clients were missing appointments. The staff were not participating in the intervention because they didn't believe in it. They weren't motivated. The service wasn't offered to young adults because the staff felt they didn't have skills to support younger clients, and clinic staff were not adhering to motivational interviewing, which is not surprising in my experience with motivational interviewing in LMIC settings, and maybe in the US, but I only have experience of using it in Malawi. So So what were the determinants, right? What are the barriers and their level of influence on the outcome? So people thought that motivational interviewing was too complicated. People said they couldn't implement what they were trained in. And when they do, they're told they're doing it wrong. They've done it before and it didn't work, right? You hear like, we've done this before, it doesn't work. The intervention doesn't fit the workflow, or we don't have the skills to provide support to young adults. So these are sort of some things, right? Like self-efficacy or compatibility. Then they tried to identify like strategies to address those things. So what are we doing to promote adoption and implementation of the program? And given what we know, what can we do to address factors that impede adoption and implementation, right? So they kind of came up with these like having program champions, revising the handbook to talk about what could be adapted and what can't be changed. Like what's the core intervention? What can you actually change? Refresher training, more on-site mentoring, feedback, and learning collaboratives to improve service delivery. So this, I really liked. What Honorary did was took the determinants, the strategies, the mechanisms, and the outcomes. So things like intervention characteristics, it was high complexity and low adaptability. So you can see he put these B, C, D, and you can kind of see how like the B's go across. So in the implementation strategy, they revised the handbook, right? And then in the mechanism, that would improve knowledge about the intervention. It would improve skill set. You can see the B, and the thought was that that would tie to acceptability and fidelity of the intervention. So it kind of like you want to just, it helps you like draw a logic model through from determinant to outcome all the way through and say like, does this actually all tie together? Like, does this strategy, like, is it actually going to do what I expect to impact the outcome? And is it addressing the determinant that we first like identified? So I just thought this was like a lovely illustration of what I think we should be doing more of in general in the field.
And that second box, those are the ERIC strategies.
Yeah,
like, that's
exactly.
where they go. Yeah.
Exactly. Yeah. And you can use like your CFR and the determinants, and you can use the ERIC for your strategies. And so like, you don't have to just like pick one thing, or like they all fit together in different places, right? Okay. So just quickly, I think, to sum it up, if you're doing implementation research, like just be more intentional. I just noticed this, like a study I'm on where they said they were using like the EPIS framework, and then I was reading all it. No one has said anything about any implementation out in any of the draft papers or abstracts. I'm like, you guys, like, you need to be calling this out, like calling out your outcomes and strategies when you say you're doing this research in your grant proposal.
Using it if you say you're going to use it.
Yeah. Be more intentional about testing strategies and tying them to outcomes. And tying our implementation outcomes to health outcomes. Like there's just not a lot of good data to suggest like if we put all this work into actually like changing the system, does it make a difference on the health outcome? And then I would also, for those of you working in LMIC settings, to really be more intentional about like adapting frameworks and outcomes. Like if you're using them, are they really working? And if not, like what about them is like not working well? What needs to be tweaked or changed? I think that is it. Just want to acknowledge on the D43 and the NIH, and Danielle and Linda Gale on the buddies.
Thanks so much. Hi, everyone.
Hi.
I'm actually from South Africa. This is very refreshing to hear some feedback about implementation science. And I see, Dr. Audrey, that you've worked with quite a few folks that we do work with. So I'm surprised I don't know anything about this implementation science D43 training. It's actually the reason why I attended the webinar, to just get a sense of the work that's currently going on in the landscape around implementation science, because I am interested and I'm doing my PhD on that, but I haven't had a good share of mentors or like proper training. I think, like you said, something I've always picked up within the work that we're doing is that there's not a lot of proper implementation science methodologies and theories that are really used properly. It's always like just mixing it in somehow in the explorative research, but not proper implementation science. So it's very interesting that you have this consortium group that is actually participating in this D43. Just also curious, like how the Wits Health Consortium, the other folks like Hero, if they could be part of that as well, and or how do the trainees get to apply for this program? Thanks so much.
Yeah, and I'd be happy if you want to connect an email. I'd be happy to send you more resources because there's quite a lot of people now doing. Actually, I think the folks, Elvin Gang and folks at WashU, I think also might have an implementation science G43 now at UKZN, and Landon Myers and folks at UCT who are part of this, I think now have submitted their own. So there's a lot, actually there's a lot of G43s in South Africa. Not all of them are implementation science, but a lot, like there's one in Malawi, there's one in Zambia. So, and I know the Nigerian group just got theirs funded recently. So there's a growing group of implementation science G43s in the region. With the AHISA network, which is adolescent focused, they also have created within country networks. So I know there was just a local meeting, forget which was in Durban or Cape Town, but I could send you details on that as well. And essentially, like you can take, so the School of Public Health, you can get your master's and get the concentration like as a 2-year degree, as a part-time degree, but you can also take the implementation science classes as short courses at Wits. And I think it's Implementation Science 101, and then there's one more which I think is more focused on I'm drawing a blank right now, but there is a second level course there. And then I know a lot of groups are also starting to offer more of these like are offered in the US at WashU and other places, but like kind of just a 1 week or a 2 week implementation science workshop, kind of thing are being offered.
We have them here too.
Yeah, there's a lot in the US,
Yeah.
but within South Africa and the region, people are starting to offer them more there as well. So I'd be happy to share some contacts with you if useful.
Awesome. Thank you so much.
Yeah.
Any other questions from the Zoom attendees or anyone here in the room?
You guys.
I mean, I don't see anyone, I don't know if anyone's raising a hand or putting things in the chat because I don't have my computer open, which is so refreshing. But I mean, I think one of the interesting challenges also, and I don't know if you want to comment on this from being on the NIAID council, but a couple of us have put in grants where we really focus on the implementation strategies and on the implementation outcomes. I'm looking at Hannah because I can see you on the screen, and we get some pushback. From NIH reviewers that are much more accustomed to acceptability and feasibility.
Yes.
And we just put in one where they were like, you haven't determined the barriers. I'm like, everyone's determined the barriers.
Yeah.
What we need to do is move past that, which
Yeah.
of course we should have probably cited the article you showed us. But I don't know if there's
the barriers are known and have been well identified. Underline.
And now you, NIH reviewer, are being a barrier to moving forward.
You are the barrier.
We are the barriers because we are also the NIH reviewers, but I don't know if this has come up at all in council discussions or what folks have to say about that, because I do feel like there's a little bit of, folks aren't used to these methods yet, and that means that some people who review them outside of the very specific implementation science review groups don't necessarily have, they're not conversant in these methods either.
It's almost, if it's not a specific RFA that's calling exactly that, people aren't valuing it equally.
Yeah.
But even if you read the literature, it's funny because I was just, doing lit reviews for this. I was like trying to type in like hybrid type 2, hybrid type 3, and then there's a ton of protocol papers out there, and they are not type 2 or type, like people also don't know what they're talking about. Like, not that I did, but like, I just think like implementation science has become this thing and people are throwing around like CFR or whatever. But then if you read the paper, like people are not actually like using the theories and frameworks and outcomes correctly. And like, I just think that there's a lot of, we don't know what we're doing. And that causes issues.
So
I can't remember a hybrid type 3 that I've in recent
reviewed,
memory.
I mean, I do think it raises the question as to whether, NIH needs an implementation science review group in HIV that can actually read these protocols, as opposed to sending them to the typical review groups that can't, that don't necessarily have the expertise, although.
There used to be, I was on it, there was DIRH.
Is that gone now?
Yes.
But that's not HIV, right? It was general.
It wasn't HIV specific, but we got the HIV, but we also got the cancer ones, but it got disbanded
Except
supposedly.
when we tried to send ours to this was mine and Wayne's, which got eventually funded, but when we requested your review group, that the Implementation Science Review Group, they sent it back to PPA, which is a HIV review group. So just to say, I think that there are barriers at the NIH level to really funding research that would push this field forward.
I agree. And I didn't see, I mean, whatever comes to council, I didn't see any implementation science grants that came across our desk during my tenure on council.
It runs counter to, I mean, there's all this emphasis on your creative, think outside the box strategy, but the reality is those ERIC strategies are not think outside the box. They're like, I mean, there's only so many, there's only so many ways to rework a workflow, but the reality is if you don't rework the workflow, it's not going to work, right?
Yeah.
And that piece of it gets lost at the NIH. And
Innovation, like, is this innovative? No.
right, exactly, right. And you have the innovation review criterion, although they're reworking everything again. But right, I mean, they haven't figured out how to take this type of science and fit it into the frameworks that they're using to evaluate.
So you should use your power on the council to do something about that.
Ha ha ha.
I see Hannah unmuted. Are you going to say something, Hannah?
Oh, I'm just generally agreeing. I think Wayne said everything I was going to say.
Yeah.
I don't see any.
Yeah. Well, we did hit 12 o'clock. And can I just, thank you so much for coming. These slides will be available, as will the talk. Rochelle will let everyone know how to get those. But I just also wanted to really plug coming here in person, because it's actually amazing to sit across the table from people and have a conversation. So for those of you who have the opportunity to come in for the next talk, I'd highly recommend it. And it's nice to see everyone.